Thank you. Thank you. Thank you very much. It's been a good 2 days and a lot of learning. And this afternoon, we are going to hear quite some powerful presentations. My name is Nkatha Njero. I am from Nairobi, Kenya. I work with the Africa Christian Health Associations platform, ACHAP. ACHAP is an organization, a regional organization, working with Christian health associations in 32 countries in sub-Saharan Africa. And the Christian health associations are national platforms for mission health programs and facilities in their different countries. More than 5,000 mission hospitals in different countries providing care in, as you know, mission hospitals are mostly found in communities, in rural communities, hard-to-reach communities, marginalized communities. And a lot of work is done by our network, including work in HIV, in stigma and discrimination. Those who attended one of the sessions yesterday, you heard us talk about the work we are doing in Kenya, Uganda, and Nigeria with religious leaders, healthcare workers, and people living with HIV/AIDS, where we are working to have dialogues, using the framework for dialogue, and we are having conversations with people living with HIV, not about people living with HIV. I learned that these 2 days. So we are having conversations, and they are telling us, and we are listening to each other. The people living with HIV are telling us why they don't want to go to our facilities, what they like about our health workers, what they like about our religious leaders, what we need to do better, and we are listening to them and asking each other questions, and we presented quite some information about that. So this afternoon, we are going to have speakers. The first speaker is Suki Bivas, the Director, Equality and Rights for All, UNAIDS Global Partnership to Eliminate All Forms of HIV-related stigma and discrimination. After Suki, we are going to have Pim Luz, PLHIV Stigma and Index Officer, the Global Network of People Living with HIV, the Stigma Index Study, and ways in which faith and groups and communities could use this tool to strengthen their stigma reduction intervention. So that's the topic of the presentation. And then Alexandrina, I'm sorry, Lovita, that I said well, who is the technical advisor, Human Rights, Community Rights and Gender Department, the Global Fund, is going to be talking about the Breaking Down Barriers Initiative, tackling HIV stigma with faith communities. So very rich presentations this afternoon on stigma and circling in on working with faith communities. So Suki, and then we will have Pim, and Lovita will go next. And you will tell us a little bit more about yourself as you come to present. Welcome, Suki.
Thank you very much for the invitation to join all of you. I'll start by telling you that I grew up in and still live in the traditional and unceded territory of the Algonquin and Anishinaabe people. And today we have the honor and the privilege of meeting on the traditional and unceded territory of the Mohawk people. And this place has long been used as a site for meeting and exchanging among nations and still is today. And I express on my own behalf and on behalf of UNAIDS our gratitude for being able to meet on this territory, and we commit ourselves to the pursuit of truth and justice and reconciliation in allyship. So thank you. Before I start, I also just wanted to acknowledge and thank the wonderful Yasik, who you all know well, who is so fantastic. Don't be shy, Jacek. You deserve that and much, much more. And also Laurel and Alexis and Julianne and all the other staff and volunteers that have helped put this together and that really help ensure our ongoing engagement with faith leaders and faith communities, which is so very important to UNAIDS and to the global response to HIV. So could I have the next slide, please? In fact, we can go on to the next one. I don't think you... Yeah, that's great. What I'm going to cover today are just three sort of major things. The societal enabler targets designed to address stigma and discrimination. The global partnership for action to eliminate all forms of HIV-related stigma and discrimination. And then what's probably of most interest to all of you, or that you may know better than I even, are some of the examples of the really fantastic work that faith-based organizations are doing in global partnership countries in pursuit of this goal. Next slide, please. So maybe I'll just start with, it's never been more clear than it is in this current global AIDS strategy that reducing stigma and discrimination and gender equality, advancing gender equality, and advancing human rights absolutely has to be at the core of everything that we do in the context of trying to end AIDS as as part of our SDG commitments and beyond by 2030. And what is truly remarkable about this is that it was agreed by governments in 2021 as part of the new political declaration that was agreed in New York. And so we now have a very different position from which to insist that this work go forward. And to support this, there are three key commitments that we call the societal enabler targets. And I'm sure you all know them, but they always bear repeating. And they are that less than 10% of countries have punitive legal and policy environments that deny or limit access to services. And less than 10% of people living with HIV and key populations, and I put a focus on both, experience stigma and discrimination. And finally, that less than 10% of women and girls and people living with HIV and key populations experience gender-based discrimination or violence. So those are very ambitious targets, but they are the key to getting where we need to go to get the response back on track. Next slide, please. So you may not be able to read this as I can't, but what it really shows is that intersecting inequalities are still what is really fueling the HIV epidemic and blocking progress towards ending AIDS. So we really have to look at, understand, and dig deeply in responding to and ending those inequalities if we want to save lives. And if we meet the HIV service targets, which are of course incredibly important, but we don't also make progress across the societal enablers, there will be an extremely high human cost. This isn't just rhetoric. This will result in the saving of or not of lives. If we don't advance sufficiently towards controlling the HIV epidemic and ending AIDS, we are all going to be, I'm sure, feeling like we didn't do the things that we needed to do and know that we have to do. The good news is that by addressing violence, stigma, and discrimination, and ending discriminatory laws, the world could avert 2.5 million new infections and 1.7 million more AIDS-related deaths. This is huge. Next slide, please. So what we know from our experience to date and the evidence that we have is that the drivers of stigma and discrimination, including discriminatory laws, remain in place in far too many countries. There has been some change, and you will hear more through a range of different sessions that are being held during the conference to follow, if you're able to join them. But that progress remains too low and too slow, but we know what to do. Action on criminal law is absolutely critical. We know that in countries that criminalize same-sex sexual activity, men who have sex with men or gay men are twice as likely to be living with HIV than other men. Drug criminalization is associated with higher rates of HIV, sharing of needles, and other HIV risk behaviors. So here are the shocking, here's the shocking data that we have. 62% of reporting countries criminalize HIV exposure, non-disclosure, and transmission, 62%. 14% criminalize gender expression. 90% criminalize possession of drugs for personal use. 36% criminalize same-sex sexual activity, and all reporting countries criminalize some aspect of sex work. So you can see we are not anywhere close to where we need to be in terms of the legal and policy environments. Next slide, please. So what these tiny numbers show you and country names show you is that we still have extremely high rates of stigma and discrimination being experienced by people living with HIV, both in healthcare as well as in community settings. That's what those two bars are. So essentially, stigma and discrimination continues to be extremely pervasive. And this includes, of course, things like discriminatory attitudes, beliefs, internalized stigma, and experiences of stigma. In the 55 countries that were included in a recent survey, the median of 59.1% of people still harbor discriminatory attitudes. Now that level is 6 times higher than the 2025 target, which I'll talk about a little bit more. In 19 of 21 countries with pertinent information on people living with HIV, the Stigma Index surveys from 2018 to 2021 show that the percentage of people living with HIV who reported self-stigma exceeded 20%. That's high. And according to the surveys in 2017 and 2020, more than 10% of people living with HIV experienced stigma and discrimination in community settings in the majority of the countries that have data. So we can see how incredibly important communities are to ending stigma and discrimination. Next slide, please. So we see a similar picture for key populations experiencing stigma and discrimination. And we're even farther away from our 2025 target when it comes to stigma and discrimination of key populations. In countries with data, 47% of people who inject drugs and 81% of people reporting, 81% of transgender people reported experiencing stigma and discrimination in the last 6 months alone. So think about those 47% of people who inject drugs and 81% of transgender people are experiencing stigma and discrimination right now. In the last few years, key population communities and organizations, particularly those made up of and working with LGBTQ people, have been facing an increasing number of violent incidents, accentuated stigmatization and hatred, and we see where social media has been really used to drive stigma and discrimination. Next slide, please. So I'm not going to say very much about the setup of the global partnership, except to say that the whole way that the partnership has been conceived and is structured is really to emphasize how important partnerships are, as the name suggests. And the Global Partnership is really a key vehicle for action to mobilize countries to reach the interconnected targets that are included in the Global AIDS Strategy. And the whole idea is that these partnerships will harness the combined power of governments, civil society, bilateral and multilateral donors, academia, and the UN, and of course, faith-based organizations to eliminate HIV-related stigma and discrimination and to inspire countries to remove the critical barriers to HIV services. So a little bit about the partnership. It's co-led by UNAIDS, UNDP, UN Women, GMP+, the Global Fund, and the PCB NGO delegation. And the PCB is UNAIDS' governing body, which happens to be the only part of the entire UN system that has communities and civil society members involved formally as partners of our governance structure. So the way the Global Partnership works is really to build a committed, coordinated, multi-sectoral, and community-driven and country-led response to effectively eliminate HIV-related stigma and discrimination. And it focuses on 6 key settings: healthcare, justice, education, workplace, humanitarian settings, and of course, the community. Next slide, please. Oh. Back to the 30 countries, but I'll just do that one thank you. I'll just do that one very quickly. You know, we're really thrilled that in a really short period of time, 30 countries have formally committed to joining the Global Partnership. And so the list of countries you probably can't see, so I'll read it: Angola, Argentina, Botswana, Central African Republic, Costa Rica, Cote d'Ivoire, Democratic Republic of the Congo, Ecuador, Gambia, Guatemala, Guinea, Guyana, Iran, Jamaica, Kazakhstan, Kyrgyzstan, Laos, Lesotho, Liberia, Moldova, Mozambique, Nepal, Papua New Guinea, Philippines, Senegal, South Africa, Tajikistan, Thailand, Uganda, and Ukraine. So you can see that, you know, these countries span, you know, across the regions of the world. And I wanted to point out that it's not just a box-ticking exercise for countries to commit to the Global Partnership. They actually make concrete commitments to translate, you know, the commitment into real action to end HIV-related stigma and discrimination. And they do this, and the Global Partnership helps do this by strengthening synergies and partnerships to implement and scale up programs and to generate and disseminate evidence-based data and measure progress. So next slide, please. Are we on the right one now? Next slide, thanks, yes. All right, so here's the other really good news in a sea of depressing news, and that is that we're already seeing how the Global Partnership is actually working and is creating and supporting change on the ground. So, among the key pillars of how the partnership works is keeping the leadership and the advocacy efforts of communities really at the heart of the way the partnership works. Some examples, the More Than anti-discrimination campaign was really successful in fighting internal stigma by showing personal stories and highlighting that everyone who's HIV positive is more than their HIV status. And it really had a focus on, empowering, urging communities to know their rights and informing stakeholders about, stigma and discrimination. Another pillar is really forging strong regional and national collaborations through the Global Partnership. And this means really mobilizing, respecting, and supporting the expertise that sits already within countries and within regions. So it's not about external people coming in and leading the way. It's about really, following the leadership that's already in communities. And then critically driving legal and policy reform and action on stigma and discrimination and human rights and gender equality barriers is at the core of the actions that are being supported by the global partnership. And we're seeing successes already. So we've had some action already taken on law reform in Benin, Burundi, CAR, Angola, Kazakhstan, and Ukraine. We've seen policy change that's taken place in Iran and Thailand, and we've seen action on discrimination faced by women and girls in Senegal, Uganda, and Jamaica. But there is much, much more that needs to be done. And I just want to flag here that, the Global Fund joining the Global Partnership has been a really important, way forward in terms of many things, including that the Global Fund can, the funds are there now able to provide some sustainable funding for this work. Next slide, please. So here's the part that's most interesting to you, I'm sure, and that is the examples of how faith-based organizations have really taken this on and are driving success and progress in global partnership countries. And probably as well as I, that faith-based organizations have always played an important role in the HIV response, including because of the strong links with community and the broad networks that you have with hospitals and clinics and health facilities. And this makes all of you really excellent advocates and game changers in the fight against stigma and discrimination. For example, in sub-Saharan African countries, you probably know that faith-based organizations provide nearly half of all health services. In Kenya, for example, 40% of health services across the country are delivered by faith-based organizations. I want to also just acknowledge and respect that in June of 2020, 300 faith leaders and representatives of faith-based organizations met on the sidelines of the United Nations high-level meeting on ending AIDS. And the event, Faith to End AIDS, Faith to End Inequality, was a really excellent opportunity to share lessons learned by faith communities in addressing stigma and discrimination, promoting human rights, and increasing access to HIV services, while exploring the main areas of action in the political declaration on AIDS and the particular role of faith responses in implementing the commitments. So that meeting was a really important catalyst for all the work that is ongoing and needs to continue to get us to our goal in 2030. So just a little bit of detail, next slide please, on some examples. And we'll start with Côte d'Ivoire, which is one of the focus countries in the initiative of PEPFAR and UNAIDS, which was launched in June 2020 to leverage global and country leadership by faith-based organizations in the HIV response. And Côte d'Ivoire works with faith-based organizations to align the activities to faith-based plans to support the national HIV response. So already that initiative has yielded the development of a national HIV/AIDS action plan for faith-based organizations from 2022 to 2025, which is really excellent and a model that we hope other countries will follow as well. And the first national consultation on pediatric HIV and TB was held in June 2021 with the participation and sponsorship of the First Lady of Côte d'Ivoire. And then I think I saw in the agenda there will be some sessions specifically on the Project Grail, which is extremely, I think, a great model. And then also, I think there's another one on RCIP, which I think you will hear more about in those sessions, so I won't go into too much detail, other than to flag them as really excellent examples. Next slide, please. Uganda and Ukraine are also two other countries where we're seeing really excellent work by faith-based organizations. Uganda is a global partnership country within the PEPFAR and UNAIDS faith-based initiative. And, you know, I think it's important to point out how uniquely placed the faith sector is in Uganda, with its widespread presence, with structures that can reach the grassroots communities across the country. And millions of Ugandans can be reached with appropriate HIV messages through places of worship every week. And over 99% of Uganda's 44 million are people of faith. So this just reinforces how incredibly important faith-based organizations and leaders are to the HIV response. And there are some success stories already in Uganda. A national religious leaders consultation on faith, stigma, and human rights led to the development of a communique that was referred to during the development of the National Faith-Based Action Plan, which covers 2021 to 2025 and is aligned with the National HIV Strategic Plan. So there you see very close connections and cooperation between the work that faith-based organizations are implementing. In the Ukraine, a textbook, HIV, Tolerance, and Faith, was published, and the church in Ukraine is a vital institution that gives, gives respectability and the model for, sending messages out to many parts of the population. And the involvement of faith-based organizations and churches in the war to help citizens has really, I think, solidified this position of trust and support. So there's ongoing work there that is incredibly important. It's important at any point, but during the war is really, really important. Last slide, please. So just a little bit on the way forward. What are the plans with the global partnership at this point? So really, we have a lot of work that we really need to do and scale up. A key focus going forward is the 12 million campaign commitment that was made during the Faith to End AIDS and Faith to End Equality event, where faith leaders and individuals and communities of faith committed to key actions to promote access to HIV services by the 12 million people who are living with HIV and still don't have quality and consistent HIV treatment, care, and support. And the global partnerships, cross-cutting and partnership-based work also helps contribute to the achievement of a range of the other SDGs. What we all want is a world where no one is left behind and all individuals can enjoy their human rights. Efforts toward law reform are key to ending inequalities, and they need long-standing faith-based organizations and partners to work together and build and combine their strengths, promote evidence-informed policy and practice, and strengthen advocacy efforts to promote supportive laws and change discriminatory ones. This is possible. And let me just end with a thank you to all of you for being here, being part of the discussions, and for all the work that we know you will carry out when you leave Montreal and go back to your communities. Thank you very much.
Hi everyone, and thank you for inviting me here today. My name is Pim Loze. I'm based in the Netherlands and I work for the Global Network of People Living with HIV. It's actually my 4th anniversary now because I started during the AIDS conference in 2018. So, thank you. And today I will tell you a little bit about the People Living with HIV Stigma Index program and the ways in which faith groups and communities can use the results to strengthen their stigma reduction interventions. Next slide, please. So for those of you who have never heard about the Stigma Index, the Stigma Index was started in 2008 as a joint initiative between GMP+, the International Community of Women Living with HIV, UNAIDS, and IPPF. Currently, it is the international partnership of the Stigma Index consists of GMP+, ICW, UNAIDS, and we receive support from Johns Hopkins University. It started as an initiative to document the experiences of people living with HIV in all their diversity with stigma and discrimination. It is a standardized research project that is led by and for people living with HIV. In 2018, the PLHIV Stigma Index 2.0 was launched. This was a revised version of the standardized questionnaire to reflect changes in the HIV epidemic and the global response. Then in 2020, so only 2 years ago, a standardized methodology was developed so that we could increase comparability between the implementations of this project over time and across different settings. So that's a little bit of background on the Stigma Index so you understand what we're talking about. Next slide, please. So this is what we call the Stigma Index journey map. Because it's not a one-off activity, it's actually a journey, just like the fight against stigma has been ongoing for years. And the vision for the Stigma Index is for this to be part of that journey. So starting in the right top, here, is the Stigma Index implementation itself, the implementation of the study. Part of that study, a large part of that study, is community mobilization. We need to mobilize people living with HIV to be able to conduct this study. Another big part of this is capacity development. The process of implementation of the Stigma Index has been set up in a way that it builds the research capacity of people living with HIV to conduct community-led research. A third important component of the Stigma Index implementation is partnership building. So the Stigma Index project fosters strategic partnerships between the networks of people living with HIV that implement this study and other key stakeholders during the implementation, but also during the follow-up activities. So thinking about these stakeholders can be academia, UN agency, key population networks, women living with HIV networks, and so on. Once the implementation of the study has been completed and the results are in, it doesn't end. So I feel like this is sometimes still a misconception when we speak about the Stigma Index. It is more than just a study. It doesn't end when we have a nice report written up and we give it to people and they read it. The Stigma Index has really been designed to gather evidence to then use that for advocacy. Otherwise, we can keep conducting these studies, but not much will change. So that's really part of the Stigma Index process. Last but not least, we need to keep monitoring its impact. What works, what doesn't work, what are our priority areas for action, etc. And that brings us back to another Stigma Index implementation, and so on. So it's just to show that it's important to really see what are the trends we are seeing in stigma, what is happening, and to make sure that we keep having that data that shows us what is happening and where to act. Next slide, please. So to make it a little bit more tangible, I've pulled out a few findings from recent reports. So for instance, in Vietnam last year, it was found that 7.2% of all respondents reported that their ability to practice a religion or faith as they wanted to had been negatively affected by their HIV status. In Kenya, this was almost twice as high, with 14%. Another example from Kenya, 13.7% of respondents reported being excluded from religious activities or places of worship due to their HIV status. That percentage might seem relatively small, but that is about 1 in 7. So that is actually quite high. In Brazil, that was 7.6%. So these are just some overall findings to give you an idea. But we can get, of course, more from this data. We can look at the relationship between this variable and other variables in the questionnaire. And just to say, the questionnaire in total has about 80 questions. So there's a lot of settings that we address in the questionnaire, so you can really find those connections with maybe other areas of HIV-related stigma and discrimination. What you can also do is disaggregate this data. Are there any differences between different populations, key populations, by gender, or maybe younger and older people? Are there any differences in their experiences? So we can really dig this out, and with that come to a more effective approach, more targeted advocacy. Next slide, please. So unfortunately, there's not enough time for me to show this video. It is a 5-minute video, but I do encourage you to have a look on our website where you can see this video or if the slides become available. But this video was made 2 years ago by GMP Plus and the Zimbabwean National Network of People Living with HIV, ZNMP Plus. And it really showcases the work that was done by ZNMP Plus to collaborate with the religious sector in following up on their findings from the 2014 study. So they found that 10.6% of all the participants reported being excluded from religious activities because of their HIV status. When they found this finding, they were like, that's interesting, we should see what we can do with this, but maybe first we should learn a little bit more about this. So they then decided to do in-depth interviews to really get more insight in their experiences. And then, together with the religious setting, they worked together to develop a framework on how to engage religious leaders in reducing stigma. And then they developed a stigma reduction guide for faith group leaders. So that is just one example, and the video will tell you a little bit more about it. Next slide, please. So I wanted to end with a few opportunities for further engagement when it comes to the Stigma Index. So first of all, there can be a stronger engagement of the religious sector in the implementation process. There can be more engagement from the start of implementation. By doing so, there will be stronger partnerships built with the PLHIV community and the religious sector. One example that I can name is to take part in what we call the steering committee. So every Stigma Index has a steering committee that comprises of different national stakeholders, and they provide oversight during the implementation from start to finish, including the follow-up advocacy. So by being part of that steering committee, there is buy-in, there is engagement from the beginning that will then build relationships to continue. Another opportunity, like I mentioned in the Zimbabwe example, is that while the Stigma Index itself is a standardized research process using a standardized questionnaire, there is the opportunity for the country team to conduct additional qualitative research. So that is another opportunity to gain more insight into what's happening regarding stigma and discrimination in religious settings. Another opportunity is to act on the evidence and recommendations for stigma reduction in religious settings. I'm not sure if in some contexts people know that there are actually questions in this questionnaire related to religious settings. So that alone, just getting the word out that there is data in this Stigma Index that can be used. So to work more closely with PLHIV community to really have a close look at this data, also the disaggregated data on stigma in religious settings, and together to develop and implement evidence-based recommendations. And last but not least, the position of the religious sector within the AIDS response can also be used to amplify the Stigma Index results on a national, regional, and global level. So I hope that gave you a bit of an idea about the Stigma Index and opportunities for collaboration. If you want to know more, you can reach me on the following slide. Thank you. There. Thank you.
This stage worries me. I hope it doesn't collapse, just to make a point. Hi, everyone. My name is Alexandrina Jovita. I am from the Global Fund, and I think my slides are going to be popping up any minute now. Thank you. So we've heard about the Global Partnership for Action on All Forms of HIV-related Stigma and Discrimination, and about the fact that Global Fund is one of the co-conveners. That's why the logo. We've heard about the great work that people living with HIV are doing through the Stigma Index, in terms of empowering the community, in terms of collecting the data, in terms of using that data to inform advocacy and action. All that requires resources. So it's really important that we put our money where our mouth is, and that's what Global Fund has been trying to do, including through the Breaking Down Barriers initiative. And if we'll go to the next slide, please. So protecting and promoting human rights and gender equality has been a strategic objective in the Global Fund strategy for a while now. We're doing that work across all our portfolio. So in every country where we have ongoing HIV grants, we're striving to ensure that at least 3% of our investment goes to support human rights programs. There is a key performance indicator that tracks that. We're trying to see an increase in investments in order to put those resources in the hands of activists, in order to put those resources in the hands of communities to implement programs to reduce human rights-related barriers to health. One of the vehicles for realizing the strategic commitment to addressing human rights and gender-related barriers has been the Breaking Down Barriers initiative. The Breaking Down Barriers initiative has been a flagship effort. It meant putting more resources in those countries through human rights matching funds. It meant supported generation of evidence. It meant supporting multi-stakeholder engagement. All that work has been continued and amplified in countries that have become members of a global partnership. So rather than starting yet again to assess the situation, rather than starting yet again to convene partners, we've made sure that the foundation that has been built through the Breaking Down Barriers has contributed to the global partnership objectives. And the global partnerships umbrella and all that commitment, renewed commitment and engagement allows us to progress further and go even further ahead. Because we have agreed to co-convene the global partnership, because we are working together very closely with GNP+, with the PCB NGO delegation, with UNAIDS, with UNDP and UN Women, we also have a very strong focus on addressing stigma and discrimination in the new Global Fund strategy, 2023-2028. We are committed as a funding mechanism, as that partnership that supports HIV and TB responses and malaria responses in countries, to continue putting resources, to continue putting the power of making things done, getting things done in the hands of the communities. So if we'll go to the next slide, this is a brief overview of what Breaking Down Barriers initiative has been. So the purpose of this initiative has been to focus, so we've taken 20 countries only, to provide resources, hence the catalytic funding, the matching funds that I was referring to provide evidence, hence baseline assessments that were conducted in 2017-2018. The baseline assessments didn't only look at the human rights-related barriers that existed in countries. They didn't only look at the stigma index findings. They didn't only look at community-led monitoring data that showed us where the problem is. They also looked at what are the current efforts in place to address those problems. So what are the programs? What are the programmatic responses? Who are the right partners that need to be involved? Following those baseline assessments, we've had multi-stakeholder engagement and multi-stakeholder processes. And this is where faith communities have been extremely engaged. So in many of the multi-stakeholder meetings that have been conducted in the countries that are members of the Breaking Down Barriers initiative, we've had faith-based organizations participate, we've had faith leaders participate, and bring invaluable insights into how do we come together, all of us, to undertake national strategic planning. How do we come up with a framework with clear results and clear objectives and clear interventions that would allow us to address stigma and discrimination across the 6 settings of a global partnership? Those multi-stakeholder engagement mechanisms, they didn't disappear after one multi-stakeholder meeting. They have continued with human rights working groups that have developed these plans. They have continued with human rights working groups that oversee implementation of those plans. The midterm assessments that were conducted and completed recently have shown the value of that continued engagement over time. We will also be conducting end-term assessments in the next year or so, so hopefully we'll be able to see even more progress. So it's a developing field of work. It's one that is showing a lot of promise. Watch this space. Let's go to the next slide. These are the 20 countries that are part of the Breaking Down Barriers initiative. As soon as they come up on the screen. You'll see that 13 of them are on the African continent. You'll see that it's a very broad range of contexts. It's not countries that are highest offenders in terms of human rights. It's not countries that are highest performers in terms of human rights. It's countries where we've had commitment, engagement, and action. And even in the most challenging of circumstances, we have seen progress. Part of that progress is the increase in investments in these 20 countries. So over time, between different funding cycles of a global fund, we've seen a more than a tenfold increase in investments. This is big money for human rights. So when we started back in the 2014-2016 funding cycle, the investment across the 20 countries was at around 10 million. In the previous cycle, 2017-2019, the investment was already at over 78 million, which is an impressive increase in investment. In the current cycle, even though it's work in progress, some of the countries like Honduras are yet to sign the last grant. But the estimation is that current investment is at over 130 million. There is a lot of great work that we can ensure that happens with 130 million in 20 countries. So there is really the hope that that investment is going to be able to resource some of that great work, to resource some of those great partnerships that need to be in place in order to be able to deliver. If we'll go to the next slide, we'll see what the midterm assessments have started to show us in terms of progress. And I know it's very difficult to see, also because I crammed a lot on one slide, but we see progress in all 20 countries. We've seen progress in terms of scaling up programs to reduce stigma and discrimination and other human rights related barriers in every single of the 20 countries, despite COVID-19, despite many other challenges that those countries have. The lighter pink bar is the status of the response at the baseline. The darker pink bars is the situation in end of 2019, 2020, 2021, when the midterm assessments were carried out. We've seen that progress has occurred across all 7 of the key programs to reduce stigma and discrimination and increase access to justice that UNAIDS recommends. All those 7 programs that need to be implemented in the 6 settings, 7 plus 6, remember? We've seen that progress has occurred across the board. We've also seen that some of those elements of progress have been premised on the engagement and involvement of multiple stakeholders. Midterm assessments have reinforced the evidence that religious leaders, faith initiatives, they have a critical role to play in reducing stigma and discrimination through respectful and compassionate care. And if we'll go to the next slide, that's basically a summary of the emerging elements of what are the prerequisites for impact. What are those ingredients of success? Meaningful engagement of civil society organizations and representatives of key populations all throughout the planning, the delivery of programs, the monitoring of programs, including through ongoing efforts such as community-led monitoring or efforts of collecting data such as Stigma Index, but also of empowering communities to be able to collect the data, to use the data, as Pim has just told us. All those have been ingredients, key ingredients of success. You cannot succeed without them. But it is really about the multi-stakeholder efforts if we are to have success. The stronger we are stronger if we work together. So the more we work together, the stronger we are. That's why multi-stakeholder commitment and involvement, including of the faith sector, has proven to be one of those key ingredients of success. It's really important that the effort is consistent and over time, and we're scaling up the human rights programs that we have in place. So say we have a great program, community-led program to reduce stigma and discrimination in one single town. It's great, but it's too little. It's a drop in the ocean. Say the programs that we have in place focus on one of the key populations only and forget about the other key populations. It's too little. It's really important to scale up towards comprehensive responses to stigma and discrimination. And for that, we really need to ensure that no one is left behind. We really need to ensure that all the key populations, all the geographic locations, all the right programs reach all the right people. And those programs need to be resourced at the right level. They need to be continued over time. There needs to be considerations of what's sustainable, what's effective, what are the quality of those programs in order to have a definite impact on reducing stigma and discrimination. If we'll go to the next slide, please. These are some of the examples of good practices that are starting to emerge from the midterm assessment reports. All 20 midterm assessment reports are available on the Global Fund site. I also have brought some posters that include some more information about this work. They're somewhere in the hallway. I'll bring them in. Some of those examples that we've seen is that where we have the involvement of all the relevant actors, including faith-based and traditional medical practitioners, in conceptualizing and delivering compassionate and quality services, where that involvement is specifically geared at tackling intolerance and exclusion. We're seeing higher coverage levels, we're seeing increased uptake of services, we're seeing increased retention. Across all breaking down barriers countries, we've seen that there are multiple ongoing programs to capacitate faith and traditional leaders on stigma and discrimination and on gender-based violence, starting from the premise that they have a critical role to play in addressing both stigma and discrimination and gender-based violence. Some of the examples of the work that has been happening in Cote d'Ivoire, I won't go into too much details because Suki has already mentioned some of that work. In Ghana, we've also had consultations with traditional religion leaders in 7 regions. So it wasn't a training. It was really coming up with a joint approach. How do we work together? Who has what role to play? How the pieces of a puzzle are coming together in one holistic picture to reduce gender-based violence. We've seen how important it is to ensure those collective efforts in speaking against oppression and speaking against rights abuses. In Uganda, we know that there have been instances of human rights violations, particularly affecting the LGBT community. The Uganda AIDS Commission has been working with the faith communities in Uganda. It has developed standardized messages on stigma and discrimination. And it has been working with religious communities, estimating that their coverage has been at above 50%. So when you have that kind of scale, that kind of effort, that kind of consistency over time, you are likely to start seeing results. We are seeing that it's important to resource those efforts, right? It's really important to ensure that advocacy has legs. It has financial resources that allows it to progress. In Kenya, NRLA has been critical in terms of showing the role that faith leaders can play. And the Faith Action Plan, which is an agreed upon engagement framework in the country, has been resourced through the Global Fund grants. I understand that through the COVID-19 grants in particular, there has been important work happening, and we're hoping to continue seeing it and seeing progress of the efforts of NRLA. In Ghana, we have an interesting example of tackling TB stigma, not only HIV stigma. So what I'm trying to say is that we're seeing from the midterm assessments some elements and some examples and some stories of good practice. I'm sure there are many more to say and tell. Let's start collecting those stories. Let's start communicating those stories. Let's start sharing those stories and learning from each other. Because now we have a unique opportunity in time. There are resources in place allowing the countries to progress and address stigma and discrimination. We know that only through working together we have a chance to address something as complex as stigma discrimination is. So hopefully we're going to be able to see even more good practices and even more evidence of impact at the end-term assessments that are going to be happening as of next year. If we'll go to the next slide, we'll speak about some next steps, what lies ahead. We are launching the midterm assessment summary report here at 8:22. It's going to happen on Sunday. Watch this space. Please come join us. It's going to be fun. A lot of the work that we intend to continue doing is premised on the outcomes of our 7th replenishment. That's the way Global Fund works. We try to mobilize resources for all those grants that go to countries once every 3 years. This is coming up again in September. The US is our host. So let's fight for what counts. Let's work together to try to ensure that that replenishment is successful in order for us to be able to continue resourcing all that great work. We intend to continue working in the 20 countries that were part of the Breaking Down Barriers initiative, not forget about them, but also expand and bring more countries into that pool. We're hoping that the 20 Breaking Down Barriers countries have already seen the value of this work and will continue to resource that work through their main grants, and we will see more investment through the main grants, and that would allow us to bring more countries into having matching funds, human rights matching funds, available and accessible. In order to access those human rights matching funds, countries need to demonstrate commitment. Countries need to meet some financial and programmatic conditions. So that's a way of getting some leadership and traction, some commitment and engagement around human rights. We will continue tracking that through a strategic key performance indicator, because accountability is important. It's not only about making resources available, it's about ensuring that those resources deliver on what they've set out to achieve. That we're seeing a continued increase in the scale and coverage of human rights programs, that we're seeing a continued level of results that those programs deliver. So we will continue tracking that for a strategic key performance indicator. But bottom line, in order to see some of that success, and the key to that success resides in our joint actions. So we're really looking forward to continue working together with the communities of people living with HIV, of key populations, with faith communities, with government representatives, with technical partners and donors, only working together, we have a likelihood of succeeding. So let's end it. Let's end stigma and discrimination together.
Thank you very much to all the powerful women that have spoken this afternoon. We have one gentleman. I hope he's here or online. Itoro, are you here or online? Okay, so again, thank you to the powerful women. I hope you didn't make him chicken out. So we have an opportunity for just 2 questions because we need from two powerful gentlemen. But also we would like to check if there's anything online. I know for most people it's probably bedtime online. But is there any? If none, then it will be the 2 powerful nothing. So we start here and then with you, John.
Okay. Thank you very much for the highly insightful presentation, and it's quite very informative. I was looking forward to this presentation on Stigma Index. It's quite something that I really want to understand quite well. And thank you very much for that beautiful presentation that gave me quite some understanding of all this. But I still have some questions, and I need. First, I want to know, when we want to measure stigma to me appear quite amorphous, and I'm trying to look at various ways stigma manifests and presents. Who should really be the focus? Is it the PLHIV or the people? Because if you look at it, there's something that is called self-stigma, which is not real. So there's someone who is HIV positive felt stigmatized, even when around him there are no actual stigma going on. So if you make the PLHIV the focus, how do you distinguish between someone who is stigmatizing himself or someone who is actually experiencing stigma? Then I also want to understand, because if you look at it very well, they say perception is everything. Sometimes these things are quite not, maybe you use the word virtual and real. So my question, and I asked this question in the context of some of the things we're doing. In the morning, we talked about these galvanized religious factors towards accelerated identification of, pediatric HIV AIDS. One of our goals in the implementation of that project is to be able to reduce stigma. And one of the challenges we have is how do we objectively, measure reduction in stigma? And I really want to know whether there are specific parameters or indicators that you can look out for and that you can actually use to be able to, concretize and give a vivid picture to what stigma was and what it has become after certain intervention. That's my question. Thank you.
Let's have both questions and then we'll get the answers.
Thank you for the presentations. And I just want to commend, from what I see in the area of public health, the ways in which Stigma Index 2.0 has become much more robust methodologically and much more contextualized to local country context. I think it's really important and marks a real step forward. I do have a question about how we conceptualize stigma and the particularities and whether the index addresses this in terms of the kind of variations of how community partners can have differing kinds of effects in regard to different kinds of stigmas. For example, if there is a religious leader who becomes a key advocate in speaking out and challenging and working to dismantle sexual and gender-based violence, but that same religious leader is also a vocal proponent of anti-LGBTQ perspectives, frameworks, policies, and programs, by amplifying their voice in regard to SGPV, are there ways in which that amplified voice might have a negative impact in actually increasing stigma against LGBTQ communities. And are we are there any ways that right now we're looking for that kind of variability in terms of impacts and effects across different kinds of context in relation to stigma?
Okay, thank you for those questions. Not sure where to start digesting the questions, sorry. Trying to take it in, I was too late to take notes. So first, let me get to your first question. To make sure I understand the question, it was about how stigma is sometimes like not visible. So how do we measure that, and that it's all about perception? Is it the PLHIV or the people? What do you mean exactly by that?
From your work, you were looking at PLHIV, your questionnaires, or the tool you used was actually looking at, trying to elicit some response among the PLHIV as to their experience with stigma. So my question is, if you do that, someone might actually be having self-stigma and the responses we sync with that, whereas around that individual, the people may have a different. So is it okay to not just focus on the PLHIV themselves and find what is happening among the people around them as to whether or not there are actual stigma going?
Okay, thank you. I understand now. So I think that's actually a request we get very often. That can we also do the stigma index among healthcare workers, or can we also do the stigma index there? I fully agree that this information is also very helpful in the response, but I just want to point out that that is not the stigma index. The stigma index is only by and for people living with HIV. This research must be led by people living with HIV for people living with HIV. If the country team or the network leading this thinks it's important at the same time to do another study to get that information, absolutely, we encourage you to do so, but that would be a different program or a different study. Another option, like I pointed out, is also to conduct qualitative research. There is a Stigma Index qualitative research toolkit to help guide this. How do you determine the priority? Do you want to do in-depth interviews or focus group discussions, etc.? So that can be conducted alongside the Stigma Index to really get a comprehensive picture of what is happening. So that's one. I think you mentioned something about internalized stigma and how that's not visible. Right, so I want to point out that in my opinion, that is just as much real stigma. That internalized stigma comes from the perceptions in society, and that in fact is stigma. There are questions in the questionnaire that there are of course many different forms of stigma and many are addressed, maybe not explicitly so, but when we do analysis, we can differentiate between the different questions. What is enacted stigma? What is internalized stigma? What is anticipated stigma? And then when we write up the report, we can make those distinctions, or the country team, we don't actually do that, to also try and address it from that angle. So that is possible. Okay, thank you. Summarize? Yes.
Maybe I'll start, and maybe I can help Pim out. Forms and roots of stigma and discrimination, forms are different, manifestations are different, roots are frequently similar. So whenever there is a devaluation of a human being, whenever there is an element of intolerance, an element of misplaced fears, usually those are the root causes of stigma. Data per se, as well as collected for Stigma Index, are not going to be able to always tell us the holistic picture. Stigma Index is going to be a snapshot of the experiences of people living with HIV. They're going to be able to tell you whether those experiences of stigma are in the faith setting or not. They will not be able to tell you whether they will not be able to paint a complete picture. Let's stop there. I think that the qualitative research that Pim has just mentioned can help continue to add those elements. If we're seeing that LGBT communities are more likely to be stigmatized in the faith settings than, say, women living with HIV, then to me, this is first and foremost an action point for programmatic interventions. Then it means that we need to continue engaging with the faith leaders to try to understand what are their concerns, to try to come up with the right approach to address those concerns and to try to come to sensitize them so that they're able to continue to provide that compassionate care to everyone, regardless of their sexual orientation or gender identity or whatever key population they belong to. So what I'm trying to say is that data is not a catch-all. Data is important to inform programmatic interventions, but it's also taking those quantitative data that Stigma Index is able to produce, taking that qualitative data that Stigma Index qualitative research tools are able to also add in order for us to be able to understand the situation better, and using those data to inform advocacy and action. And sometimes that's the missing step, and it's really important for us to continue doing that programmatic intervention and doing it well, and using data to guide us in that programmatic intervention. Pim has also mentioned the importance of triangulating with other research. So maybe we have standardized tools for researching healthcare providers, maybe less so for faith-based healthcare providers. Maybe it's about adapting the existing tools so that we understand the other side of a coin, so that we understand the other side of a story. But understanding that, understanding where is those fears and stigma coming from, and addressing that is really important. Do you want to add?
Can I just respond and to say thank you for the way you just described the complexity and that challenge on the ground and in research in relation to the of data and a work like the Stigma Index to programs. As I said, I really want to applaud GNP Plus and others who've worked to develop Stigma Index 2.0. It really is robust, and I appreciate it. But I think sometimes when I sit in meetings, particularly in faith-based settings, because that's where I work, we speak about stigma as something monolithic, and we talk about the key roles that our faith partners play in addressing stigma. And I think everyone in this room, in various ways, is deeply committed to that work. But I think conceptually, we have some work to do to recognize that the kinds of networks and partnerships that we're involved in, not just in this room, but in beyond this room, may be carrying out activities that at times work to challenge stigma and hopefully reduce it over time. But the same kinds of networks may actually amplify stigma. And that's not yours to figure out necessarily or to fix, but I think it's ours to get our heads around the idea that the multiplicity of context in which stigma happens in regard to different communities and populations requires us always to interrogate those kinds of ways in which these kinds of dynamics play out.
That's a great point, and I think that's why those steering committees that Pim was speaking about when we plan for Stigma Index are so important, because hearing from those perspectives of faith leaders to inform how exactly do we collect the data for Stigma Index, what exactly are some of the questions that we may want to drill into through qualitative research is going to be really important. So let's work together.
Thank you.
Yeah, I really don't have much to add to that. But just to also acknowledge that the Stigma Index is indeed, I think it's important to recognize that it is a global project. So yes, it has a lot of questions. Yes, it's being implemented in a lot of places, but it also has limitations when it comes to country-specific contexts or yeah, no, mostly that's a giant limitation, of course. To really put those findings back into context, that is really important when it comes to the Stigma Index. So that's why the report should really provide that information. And also why we so strongly encourage qualitative research to happen on the side. Maybe just to quickly mention, there's one other possibility to add a few quantitative questions. But since it's a rather long questionnaire, not too much, but it's of course very different kind of data. So if there is a question where you think it would be useful to have some numbers first before maybe you do qualitative research, that is also a possibility. But like Alexandrina mentioned, it's really supposed to give you a snapshot, give you something to work with, but then when it comes to your priorities, it's important to dig deeper.
Thank you. Thank you very much, and I know we want to continue this conversation, but unfortunately we have to take our break now. There are probably things you don't see that I'm seeing on this side that include that some very red zeros that show that there is no more time. So thank you very much. We are grateful for that session. We look forward to hearing at our next conference more conversations talking about what now the faith communities will be doing on the global partnership.
Thank you, Nkatha, and thank you to our presenters.